Now, how would you decide once you've identified they've got significant prostate cancer, out of that whole realm, how do you decide which to use HIFU with?
Okay.
What is your ideal HIFU candidate?
It's based on physics. So all the treatments we use have to obey the laws of physics. HIFU is wonderful because it's completely non-invasive. Patients love that attribute. No needles, nothing, no cuts. But obviously we treat from the rectum. And I have a fixed focal length of 4 centimeters.
Mm-hmm.
So from a rectum here, which is providing my beam, that's my limit. And in fact, because we have to treat with a margin of 5 millimeters or so, remember, all cancer is treated with a margin. Some people think it's just prostate cancer that's treated with a margin. All cancer is treated with a margin because you only see the tumor, you don't see the microscopic extension. So if the cancer is, say, here, in the left anterior horn, I would want to make sure that our ablation zone encompass that. So I want to get capsule, but I also want to get at least 5 millimeters in front of the tumor.
Okay.
And HIFU, as you know, it's the far field that's hard. So I want lots of room to get a good ablation in front of the tumor.
Okay.
So I want my tumor not at 4 centimeters. I want my tumor about 3 centimeters, so I can get a really good anterior treatment.
Okay.
And when I'm treating, of course, the prostate swells, and I don't want it to swell out of my field. So it's this line really. Obviously, it depends on prostate volume.
Okay.
If the prostate measures 30 or 40 mils, there's no bit of the prostate that you can't get. But obviously, if on a typical gland, your sphere of influence, so your HIFU might be used in this part of the prostate.
Okay.
And you would struggle a little bit here.
Okay.
Now, obviously, with men, you can shrink the gland now, and you can shrink the gland by about 30% by exposure to a hormone for 3 months. But they get impotent, and this is exactly what you're trying to avoid.
Okay.
I suppose the other area, if we look down at the prostate, so this is the axial view, this is the coronal view, so it's the bladder here. I suppose the other area that's very difficult to treat is the extreme apex.
Okay.
Apexes are fine, and it's the extreme apex. Why? Because you just run out of room to apply that 5 millimeter margin. And so when I'm looking at a patient, when we're discussing an MRI with a patient, all the patients see their own MRI, I'm looking for a discrete lesion that's clinically significant to which I can apply a 5 millimeter margin.
Okay.
And it's amazing how many patients that includes.
Really?
Yeah.
Okay.
Obviously, if it's very, very apical, they're better off having a treatment that applies a margin outside the prostate. And that's called surgery or radiotherapy.
Now, what if they have
cryo wouldn't work there.
Multiple lesions on either side is not an ideal candidate in your opinion?
So I'm very happy to treat these men. And it's very unusual for a man just to have one cancer. Most men have got 2.3 cancers on average.
Right.
And what men typically have is a dominant lesion and then a lesser lesion. Now, in active surveillance, which is widely adopted and widely recommended, we apply that treatment based on a threshold of risk. So if you have low volume Gleason 3+3, you say to the patient, we don't treat you because your risk of dying from this is 0. Yeah?
Right.
This thing is non-metastatic.
Right.
Therefore, we can apply exactly the same criteria as active surveillance, but instead of applying it to the prostate,
Okay.
we can apply it. Sorry, instead of applying it to the individual, you can have active surveillance. We can apply it to the prostate.
Okay.
And I can say, well, this lesion is below our threshold of risk, therefore we can monitor it. There's very little benefit will result from us treating it, but this lesion is above our threshold of risk. We wouldn't do active surveillance, and we wouldn't watch it, and therefore we can treat it.
Okay.
So I'm very, very happy, and we've published on this fairly extensively and defined where these thresholds we think should be, of what we treat and what we observe.
Okay.
And it's the only thing that makes logical sense. If you insist that everybody is clear of cancer, there's no such thing, because the best sampling device we have samples at 5 millimeters. And this is the most precise sampling technology we have. And of course, cancers can be clever and can evade detection.
Okay.
Right? And so 5 millimeter sampling gives us a 95% chance of being sure, if the test is negative, that the man doesn't have 0.2 cc's or more. So we can be 95% certain that the man does not have anything that is greater than 0.2, not greater than or equal to 0.2 cc's.
Okay.
And that's the best we can do. So I never tell a man he's clear. I always say we've not found any clinically significant disease. And with MRI and biopsies, we can get to the same precision as 5 millimeter sampling. And again, we've published fairly extensively on this. You don't have to stick a needle every 5 millimeters. MRI actually detects the same threshold. And so this would be a typical case. A man would be biopsied. We might find some Gleason 3+3 here with some indeterminate MRI, clear lesion on the right. He would have a focal HIFU treatment to that zone there.
Okay.
And that would take about 50 minutes. We'd leave him with a catheter because of the swelling.
Okay.
Might not need a catheter. Be discharged the same day. Catheter out on day 3. And then an MRI we tend to do it 1 week later, just to make sure that the energy that I exposed the patient to resulted in nice, confluent necrosis.
How much later was the MRI?
7 days.
7 days, okay.
What do we tell the patients? And so obviously here, the level of detail that we need to treat selectively is much, much greater than a urologist needs if he's removing the prostate. All the urologist knows that there's cancer present, and the rest can be found out at pathology. If you're leaving it in, we need to be absolutely sure where everything is.